Hello, everyone. I want to thank FOHS and ACGIH so much for the great honor of being asked to give the Jeffrey Lee talk. I did not have the pleasure of knowing Jeff Lee, but I want to thank Chris Lazish Davis for giving me some insights into what a wonderful and dedicated person he was. Chris also told me that Jeff had a great sense of humor. So he may have appreciated a quote attributed to another hygienist who we lost this year and greatly loved, Mark Cousineau, who was the chief hygienist in Ontario, Canada. Mark was quoted as saying that old hygienists never die, they just go below the detection limit. But I think Mark was wrong because we continue to detect the influence of people like Mark and Jeff in much of what we do. So today I'd like to talk to you about some lessons that I and maybe some others have learned from experience of the pandemic that relate to occupational and industrial hygiene profession. And these are some of the topics I'll cover today. But first, I would like to give you a brief introduction to Workplace Health Without Borders, the organization that I volunteer with and am currently on the board of. We're an all-volunteer nonprofit organization that was founded in 2011. Our international group is headquartered in Canada, and we have branches in the US, the UK, and Australia. Our goal is to provide occupational hygiene, health, and safety knowledge to underserved areas of the world through training, projects, and research. And here's a depiction of some of our projects. We have a very active brick kiln committee that has worked on addressing hazards from brick kilns in Nepal and Pakistan, Egypt, among other places. Some of our projects have involved designing local exhaust ventilation with local materials. We also have a very active committee working with waste workers, especially in Brazil. We had a project to assess exposure of stone crushers in Tanzania. And we're helping to prevent silica exposure at gemstone processors in India. We also have a very active training program, and prior to the pandemic, we delivered training programs in a number of different countries, including India, Tanzania, Vietnam, Botswana, Mozambique, Swaziland, South Africa, and Zambia, among others. Since the pandemic started, however, we have been giving all virtual programs. I'll tell you about in a minute. We have a mentorship program that matches experienced occupational hygienists with new hygienists who want technical and career guidance and may not have access to local hygienists. As mentioned, since the pandemic started, all of our training has been virtual. We have been involved in giving multilingual basic occupational health and safety awareness training to people in Africa, Brazil, India, and a number of other countries. We've been using the OHTA, Occupational Hygiene Training Association, Basic OHS Awareness e-course, and we combine that with tutorials given in multiple languages. So far, we've given it in French, English, and Portuguese tutorials, and we're also developing a tutorial group in Spanish. Since the pandemic started, we have been giving many webinars related to COVID-19. We've given 19 of them since the pandemic started on many different topics, as well as what's happening internationally. And you can see most of our presentations are on our YouTube channel. The URL is listed here, so I do invite you to take a look at them. The vision and mission of WHWB is listed on this slide. And you can see that we've changed the vision statement a few years ago to encompass families and communities, not just workers. And this is key to what I want to talk about today, because what we do as occupational hygienists extends beyond the workplace. So what do we mean by without borders? Well, when we first formed WHWB, our name was really only a working title. that stuck. We used it because everybody understood right away what we meant. They assumed, and so did we, that it meant geographical borders. But as the years have gone on, during our 11-year history, we have learned that other kinds of borders are even more important in terms of creating barriers to achieving our vision. These include cultural differences, socioeconomic barriers, the borders between the workplace and the world outside it, and borders between professions and disciplines. In this talk, I want to briefly mention the borders between the workplace and the world outside, but then focus on the borders between disciplines, especially as they relate to the experience of the pandemic. And then I want to touch on how terminology and conceptual barriers can keep us out of the broader global health discussion and encourage us all to think about how to break down these barriers. So given that the word occupational is embedded in the name of our profession, at least in some areas it is, we have traditionally defined our job as addressing hazardous exposures within a workplace. This distinction, however, between workplace and non-workplace hazards now seems to be a false one. We especially learned this in situations where work is not performed in a place separated from home or community. And in this slide, you see some photos that I took. The top one is in Dar es Salaam on a street where people were doing welding for their car repair business. And the bottom one was taken on a project that we did in Gujarat, India, with work involving processing agate stones where there was very high silica exposure. This is a home-based industry where children and family members, as well as the workers, can be exposed to hazardous silica concentrations. And in the top picture, I think you can see that the entire community may be affected by the welding fume that was emitted from the car repair operations. So in situations like these, we are concerned with exposure to hazards, regardless of whether it is the workers who are exposed or family and community members. And this has been especially relevant during the pandemic, where there has been much discussion about workplace outbreaks of COVID-19, often leading to futile disagreements about whether a given outbreak originated in the workplace or in the community. The fact is that the virus does not care how we define borders of any kind, be they around a workplace or around a country. We know that when it comes to COVID, what happens in the workplace does not stay in the workplace. And conversely, what happens in the community affects and infects the workplace. So in protecting workers, we have had to bring our occupational hygiene knowledge to the community. And we have learned that our profession's understanding about assessment and control of hazards is valuable, whatever the setting. As a profession, we have certainly stepped up to the plate in providing resources on preventing the spread of COVID-19. The organizations whose logos are on this slide, including ACGIH, have all provided wonderful resources that have been valuable to professionals, workplace parties, and the public. But there has been a disconnect between our profession and the major drivers of public health policy during this pandemic. One is the lack of recognition of how to control COVID within the workplace. For example, in Canada, ministries of labor, which are the OSHA equivalents, conducted COVID workplace inspections, but they have been largely driven by public health authorities in terms of what they say and require about transmission and control measures. The kind of expertise that industrial hygienists can bring to bear was not being fully utilized for the most part. And this leads to the second type of border I want to explore, the border between professional and research disciplines. To a great extent, this exploration is based on lessons learned from the debate over aerosol transmission of SARS-CoV-2. I think a lot of you know that aerosol scientists, as well as industrial hygienists, were early advocates of looking at the possibility of aerosol transmission of SARS-CoV-2. And on this slide, you see a tweet from Lindsay Marr, an aerosol scientist who's been front and center of this discussion. As you can see, she advocated looking at aerosol transmission back in March 2020. And in another depiction on this slide, you can see an excerpt about a letter written by the WHWB board to Canadian public health authorities in April 2020. Most of us are well aware of the letter signed by 239 scientists, headed by Lydia Marowska and Dawn Milton, calling for addressing airborne transmission of coronavirus disease. And certainly the ACGAH, along with the AIHA, have been in the forefront of this work since the beginning of the pandemic. So what we have seen in this debate over aerosol transmission may in part be due to a clash of alternate paradigms. So let's think about what paradigm means. It has been defined as a distinct set of concepts or thought patterns, including theories, research methods, postulates, and standards for what constitutes legitimate contributions to a field. So we're going to tear this definition apart a little bit. Those clashes center on two aspects of the pandemic, of the definition. One is the theories, concepts, and thought patterns, in this case, centering on droplets versus aerosols. The second is research methods and standards for what constitutes legitimate contributions, and I will discuss that a little bit later. But first, let's concentrate on the theories, concepts, and thought patterns related to droplets versus aerosols. So the main theory that has driven public health messaging since the start of the pandemic is rooted in a paradigm that is based within the infectious disease profession, a theory that we are all by now quite familiar with, that characterizes transmission as occurring mainly through respiratory droplets that spray from an infected person onto the mucous membranes in the face of the person who becomes infected. This has been disputed by totally different professions, mainly aerosol scientists, but also industrial hygienists and other experts. But you are no doubt very familiar with this science, and if you want to review, I invite you to view several of WHWB's webinars on this topic available on our YouTube channel. This disagreement is embodied in the two quotes shown on this slide. The one on top is from an infectious disease doctor named Michael Klumpus, who wrote this quote in JAMA, the Journal of the American Medical Association, in 2020. And this was typical of statements from the infectious disease community. He said, droplets are described as entities larger than 5 microns that rapidly drop to the ground by force of gravity within 3 to 6 feet of their source. And aerosols are smaller particles that rapidly evaporate. So that's one set of, quote, facts. And then we have some alternative facts, a phrase popularized by a certain advisor to a US president. This one is put forward in the bottom quote, quote from Jose Luis Jimenez, who's been very prominent in this discussion. And he has pointed out that for aerosols of 5 microns in size to fall to the ground quickly, gravity on Earth would have to be 100 times larger than it is. And this may happen on some stars, but it's not really likely here on Earth. Now, Michael Klumpus, quoted on this page, is an example of how the minds of some infectious disease experts have been changed over the course of the pandemic. He is now a proponent of the idea of aerosol transmission. So though there is still resistance within the infectious disease world, understanding of aerosols and how they can transmit infection has gained acceptance over the past year. And with this has come some understanding and appreciation that physical sciences have a lot to teach us about disease, although they would seem to be outside the sphere of medicine. And this has been sort of really exemplified, fortunately, by recent initiatives from the White House that have developed materials and recently hosted a webinar speaking about the airborne transmission and calling for clearing the air about COVID-19. Now, going back to look at what led to this, a very interesting article appeared in Wired magazine last year, which described the different paradigms that govern the way aerosol scientists and medical professionals explain COVID-19 transmission. And as this article described, in the siloed world of academia, aerosols had always been a domain of engineers and physicists, and pathogens purely a medical concern. So this article goes on to describe a number of examples of these conflicting paradigms, including a meeting between aerosol scientists and World Health Organization, WHO, infectious disease specialists that occurred in April 2020, in which the WHO scientists told Lydia Marowska, one of the most eminent aerosol scientists in the world, that she was wrong about particle behavior. And here we see the WHO, quote, fact sheet issued in March 2020, rejecting the idea that SARS-CoV-2 is airborne. Now we have a more academic explanation of just this kind of process through an article written by historian Katie Randall, along with Jimenez and others. And this is a very interesting article about where the droplet theory of infectious disease came from and the historical basis of this paradigm, characterizing it in terms of the, quote, swinging pendulum of respiratory disease transmission. I really recommend that you view this article. A popularized description is provided in the Wired article I referenced in the previous slide. So Randall and et al. Trace the origin of the 5-micron particle size error to a historical confounding of the size of particles that reach the deep lung and they confound that with the settling properties of particles. So we know that size of particles is important to those two phenomena, but they're very different phenomena. And the influence of particle size is different for each. So what reaches the deep lung and how they settle in air. But those two things have been confounded, leading to the theory about 5-micron size particles being the distinguishing size between aerosols and droplets. So interestingly for us, the research on which the relationship of particle size to lung deposition was based was industrial hygiene research. And a study they reference in this context was published in the Journal of Industrial Hygiene in 1940. So after looking at this history, the authors of this paper call for a much better interdisciplinary discussion and collaboration. They close their article expressing the hope that a historical perspective will enable productive communication among various scientific and public health communities. And hopefully that will inform better policies as we go forward. So going back to the definition of paradigm, the other key aspect of the definition has to do with the research methods, postulates, and standards for what constitutes legitimate contributions to a field. In other words, what constitutes acceptable evidence. Now, an example has centered around the medical discipline's elevation of randomized controlled trials, abbreviated RCT, as the gold standard for evidence of the efficacy of an intervention. And this is part of the framework of evidence-based medicine, and that's abbreviated EBM, which ranks quality of evidence along the continuum. And this has been described in several articles by Guyot and others, one of which is referenced here. So they say that randomized controlled trials are at the top of this hierarchy. And you may be familiar with RCTs, especially in the context of testing drug and vaccine efficacy. And we've kind of all taken a crash course in that this year. In an RCT, different treatments are applied to different groups of subjects who are then followed to determine differences in the outcome of interest. So while RCTs are appropriate for use with drugs and vaccines and medical interventions, there are major problems with the insistence that they are the only accepted way of ensuring that a given intervention works. But we have seen this insistence coming to the fore in many interventions that have been proposed to control COVID. Now, there's become rather a specialty in the philosophy of science that has been mounting eloquent critiques of those who have been termed randomistas, those uncritical adherents to RCTs, who refuse to acknowledge the validity of evidence from other sources. And Trish Greenhaw is one of the most vocal and eloquent writers in this sphere. She's pointed out, and this is a quote from one of her papers, that the assumed superiority of RCTs may be appropriate in the sphere of medicine, but not necessarily in the arena of public health policy. So as Greenaw and others have pointed out, evidence-based medicine theories fail to distinguish appropriate evidence for different purposes. In particular, it does not recognize that we rely on the disciplines of physics and engineering to assess efficacy and safety of some interventions. And here is a recent example from Canada. This is from an opinion piece that appeared in the National Post, it's a Canadian paper, from a medical officer of health in a municipality who said he stopped wearing masks to prevent against COVID because there is no good randomized controlled trial evidence for mask effectiveness. And he said that skeptics who wait for randomized trials have been proven right. Well, there was a letter to the editor written in response to that opinion piece, was sent from a physician and 2 engineers that I think had an excellent summary and critique of the problems with randomista thinking. And one of the things they pointed out was that while RCTs may work well in complex biological systems, they are not appropriate to safety systems. And they reminded us that we trust our lives to technology like bridges and airplanes, and I would add safety harnesses and all sorts of things that are never tested through an RCT, but are tested through engineering studies. So this is a takedown of a randomistas was conducted in a satirical quote study that attempted a systematic review of randomized controlled trial evidence for parachute effectiveness. And you can see on this slide the objectives that were proposed for this study to determine whether parachutes are effective. They did a systematic review by looking in data sources in all the usual places. And what were the results? They were unable to identify any randomized controlled trials of parachute intervention. Surprise, surprise. So what they concluded, no randomized controlled trials of parachute use have been undertaken. So the basis for parachute use is purely observational, and its apparent efficacy could potentially be explained by a healthy cohort effect. And then they conclude that individuals who insist that all interventions need to be validated by a randomized controlled trial need to come down to earth with a bump. So I think that kind of effectively dispenses with the applicability of RCTs in safety situations. But satire aside, we ran into a similar disagreement in discussions over a study that was being conducted in Canada, comparing infection outcomes between healthcare workers who use medical masks versus those who used N95s. So the apparent irreconcilable differences between the researchers and some in the occupational hygiene community was, I think, based on the medical community's refusal to rely on laboratory and engineering-based tests of fit and filtration efficiency. So they felt that only RCTs could give a valid indicator of efficacy. And some hygienists, as well as nurses unions, thought that it was unethical to have one of the research arms based on subjects that had inadequate respiratory protection. So through this experience, I was introduced to the concept of equipoise. Now, no, that's not a dance term, though it sounds like one to me. It's a concept pertaining to research ethics that says a subject may be enrolled in a randomized controlled trial only if there is true uncertainty about which of the trial arms is most likely to benefit. In the case of the respirator study, the researchers did not feel that equipoise applied because they were truly uncertain about whether medical masks or respirators were better. But of course, there's no such uncertainty among industrial hygienists. And this is another instance of disagreement about acceptable evidence and failure of understanding across disciplines. So these issues are related to evidence, are also critically related to the precautionary principle. Now, a foundational tenet in our profession is that where there is uncertainty about whether a control is needed, we should err on the side of caution. And this was a fundamental and important conclusion of the report of a commission on the first SARS epidemic in Ontario. And this document, depicted here, was led by a commission led by Justice Archie Campbell, who's since passed away. And we consider that a kind of foundational document in public health, at least we in industrial hygiene community, we do. And some of the key conclusions of that report are shown on this slide. So Justice Campbell said that worker safety relies on the precautionary principle, that reasonable action to reduce risk should not await scientific certainty. And he also said where there is reasonable evidence of an impending threat to public harm, it is inappropriate to require proof of causation beyond a reasonable doubt. So all that made a lot of sense to us. However, there is no universal take on the precautionary principle. Like anything, benefits need to be balanced against costs, and I don't necessarily mean financial costs, but other downsides. And as we can see from this quote, the perception of costs and benefits can vary widely. Now, this quotation is from a very good recent article in Nature, the reference is here, that covers pretty much the same ground as that Wired article and Randall articles I showed you earlier. And it quotes some physicians who see the cost, that is the downside, of using N95s as outweighing the benefits of using them on the basis of the precautionary principle. So this is another area where we have some disagreements between our profession and others. Our expertise is needed here too. So not just about the benefits of good respiratory protection, but in making sure the downsides do not and are not perceived as outweighing the benefits. So this experience also points to the value of collaboration and cross-pollination among different disciplines in advancing scientific understanding. We have also seen that industrial hygiene research played a big role in understanding the relevance of particle size to health, but that a misinterpretation of this relevance led to major errors with big health consequences. And as a profession that bridges the disciplines of physics, engineering, chemistry, and medicine, we are very well placed to foster this cross-pollination and help prevent this kind of misunderstanding from happening again. We also need to remember that our profession has a lot to contribute to a variety of social ills, both within and outside the workplace. Yes, we cannot give up our commitment to protecting workers, but at the same time, our expertise can add a lot to preventing exposures in the community and the environment as well. So in this regard, it's important that we align with the United Nations Sustainable Development Goals, abbreviated SDGs. I want to commend Andrea Hidinga, past president of the International Occupational Hygiene Association, for being such a strong advocate of the need for industrial hygienists to be more aware of the SDGs and have a louder voice in advocating for healthy and safe work as a critical global priority. The SDGs are the foundation for setting worldwide objectives for achieving a better planet. This is the language the world is speaking when it comes to advancing the things we all care about. Our profession has a lot to offer in advancing toward these goals. I think that if we convey our perspectives and priorities in this language, we will stand a much better chance of integrating them into the global agenda. So I'd like to spend a little time in thinking about the goals that are especially relevant to us. What we do lies at the intersection of goals 3 and 8, though other goals are relevant as well. So goal 3 is related to health. The goal says that we must encourage healthy lives and promote well-being for all at all ages. And one of the targets within this goal is to substantially reduce the number of deaths and illnesses from hazardous chemicals and air, water, and soil pollution and contamination. So I guess you can see that this target is critically related to the mission of industrial hygiene. Goal 8 is concerned with decent work, in particular, as defined by the ILO, and Goal 8 talks about to promote inclusive and sustainable economic growth, employment, and decent work for all. So we need to understand what is meant by decent work. And it's been defined by the ILO, the International Labor Organization, as providing opportunities for work that is productive and delivers a fair income with security in the workplace and social protection for families. Now, within this goal, there are a number of targets, and the one that's most relevant to us is target 8.8, which is to protect labor rights and promote safe and secure working environments for all workers. So at least they get safety in there. I think that that's reassuring, but perhaps like me, you may be asking yourselves, where is health in the definition of decent work, and why is not health more prominent in these goals, in Goal 8? And why is the workplace not one of the concerns in Goal 3? We need to be advocates to make sure that these are there, that health in the workplace is really prominent as part of the SDGs. There are efforts underway to enshrine the right to a healthy and safe workplace in the ILO's list of fundamental rights at work. And I do hope that members of our profession will be strong advocates for this recognition. This is important as a way of placing us solidly within global health, environmental, and development priorities. Occupational hygiene and health have been sorely lacking as global priorities, and we must define ourselves in terms of these goals and be heard as voices calling for recognition of occupational health and hazard prevention as critical to advancing global health. And in this regard, I'd like to turn to the appeal for today's lecture, which leads to the opportunity to highlight the work of ACGAH as a global voice for control of hazards. I think you know that governments all over the world use the TLVs as exposure standards, to the extent that TLVs has become almost a household word in our business. The TLVs are used so widely throughout the world that they risk becoming invisible. Kind of reminds me of housework, which we don't notice except when it's not done. As members of ACGAH and supporters of ACGAH, we have the opportunity to make this work more visible, not only through our contributions, but also by showing how critical our knowledge of hazard assessment and control, both within and outside the workplace, is to making the world a safer place. So I have focused in this talk on several issues that may seem unrelated. And so I want to take a little time to reiterate what I see as the connection between them. The concepts and frameworks that have separated industrial hygiene from the institutions that set priorities for global health, and the need to transcend these barriers for the good of both our profession and the health of the world. In some examples, I cited the interdisciplinary boundaries created by differences regarding standards of evidence and the under-recognized relevance of fields like aerosol science to health. We have learned about the need to be more vocal in arenas outside those we are familiar with. It should not have taken the kind of persistent struggles for recognition of aerosol transmission that were necessary to get to this point, but it did. We can only hope that going forward, this can be an example that will embolden us to advocate for application of our expertise and also help those with different perspectives open their minds to new ways of seeing things. And similarly, we need to be more vocal in showing what we can contribute to the Sustainable Development Goals in several ways. One, about the importance of healthy and safe working conditions to overall global health. And second, about the kinds of knowledge and expertise we can bring to eliminating health hazards, and whether they arise at work or outside of it. I want to thank Chris Lazish-Davis for pointing out to me that there have been long-standing debates within the industrial hygiene profession about where our boundaries are. And recently, we have been landing on a definition that favors the broader rather than the narrower concept. So in this regard, you probably know that AIHA has been rebranding itself and the profession, emphasizing that our knowledge extends beyond industrial hygiene and extends beyond the workplace also to encompass environment and public health. Or as my husband said when he was editing one of our webinars that talked about this, maybe AIHA means it ain't just industrial hygiene anymore. So I am hopeful that all of us as individuals and organizations will continue to overcome these borders so we will achieve our greatest potential in ensuring a healthy planet. I would love to be able to carry on this conversation with you and discuss it in the time we have left today or at any other time. I invite you to join Workplace Health Without Borders if it interests you, or just get in touch if you want to ask about or comment on anything you have heard. And again, I want to thank FOHS and ACGAH most deeply for this honor. Thank you.